Good day. Today we'll discuss our discussion on evaluation of articles on diagnosis. And these are my references. Now, I would like to talk first diagnostic tests. Diagnostic tests help physicians revise disease probability of their patients. I'll be talking of disease probability in this discussion, and diagnostic tests will our help physicians revise disease probability. You see, all tests should be ordered by the physician to answer a specific question. And there are 5 reasons why physicians want to have a diagnostic tests. And these are the 5 reasons. First is to establish a diagnosis in symptomatic patients. So for example, an ECG to diagnose ST elevation, STEMI, ST myocardial elevation, myocardial infarction in patients with chest pain, STEMI. The second is to screen for disease in asymptomatic patients. So for example, a PSA in men older than 50 years old. The next is to establish prognostic information in patients with established disease. For example, a CD4 count in patients with HIV. Now, the next is to monitor therapy by either benefits or side effects. For example, measuring the INR in patients taking warfarin. And lastly, a test may also be performed to confirm that a person is free from the disease. So, for example, a pregnancy test to exclude the diagnosis of ectopic pregnancy. Now, when we talk of diagnostic tests, we need to look at a criterion test. A criterion test, that's also called a reference standard test, definitively decides presence or absence of a disease. So for example, example of a criterion standard test includes pathological specimen for malignancies. It can also include pulmonary angiography for pulmonary embolism. You see, class, when we talk of accuracy of a test, accuracy of a diagnostic test, we need to have a criterion standard test. And however, criterion standard tests, while they definitively say presence or absence of the disease, they come routinely with drawbacks. They are usually expensive, less widely available, more invasive, and riskier. And these issues usually compel most physicians to choose other diagnostic tests as surrogates for their criterion standard test as an alternative for their criterion standard test. So for example, venography, that's a criterion standard test for vein thrombosis, is an invasive procedure with significant complications including renal failure, allergic reaction, and clot formation. And these risks make venography less desirable than the alternative diagnostic test, the venous duplex ultrasonography, or a duplex scan. Now, the price, however, that most diagnostic tests pay for their ease of use compared with their criterion standard test is a decrease in the accuracy. Now, how to account for this trade-off between diagnostic accuracy on one hand and patient's acceptability on the other hand, or ease of use, is the subject of this discussion. Now, I told you a while ago that in this lecture, since I am a biostatistician, I would like to focus my discussion on pre-test and post-test probability. So we talk of probability of a disease, a pre-test probability and a post-test probability. Don't be afraid, this only seems difficult to understand, but it is not really that difficult. Okay, let's begin with the pre-test probability. What does that mean? You see, every clinical encounter begins with an initial impression. You see a patient, and then you interview, you do history taking, you do physical examination, and then you will have an initial clinical impression. And we call that initial clinical impression as the subjective pre-test probability of a disease. Why is it called subjective? It is called subjective because it is just based on the assessment of the physician, subjective assessment of the physician, based on history and physical examination. Now, and so what do we do after a clinical impression or a pre-test probability of the disease? We request for laboratory examination. And the ultimate goal of all diagnostic testing, laboratory exam, is to refine this pre-test probability to the point where the physician can confidently make a treat or no treat decision. Meaning, after you get the results of the diagnostic testing, you refine now that pre-test probability to the point where either you treat if the laboratory results show positive findings, or you don't treat if it shows negative findings. And so you refine that pre-test probability. Now, each diagnostic test, whether it's a laboratory or a radiological examination, results in the change of the physician's probability of the disease, the post-test probability. The pre-test probability, as we said, is the probability of the disease or the initial subjective impression of the physician, and then after doing a laboratory examination, so it could be laboratory, it could be radiologic, or what have you, and then you now refine the pre-test probability, you now make a post-test probability, meaning after the laboratory examinations, what will be the probability post-test? What will be the probability of that disease? Now, the degree to which a diagnostic test increases or decreases the probability of the disease from pre-test to post-test represents the clinical utility of the test. So, okay, let me just explain this further. Okay, we have a pre-test probability. And I would like to say to you that when we talk of probability, we are talking of numbers, probability, percentage. What is the probability that the patient has the disease? That is the pre-test probability. So you assign a value to say the pre-test probability. We'll give an example in a little while. Now, clinical studies of diagnostic tests measure the accuracy of a test against its criterion standard. We told you that a while ago. And I would like you, class, to look at this table, and I would like to believe that you're familiar with this table. We discussed this table when you were in the second year, except that we discussed this table in terms of the research design, So this table, when we talk of accuracy of the test in terms of sensitivity and specificity, we can also be talking of this table. The columns represent the disease, and then the rows represent the result of the test. So so A are people who have the disease and they test positive. So they have the disease and they test positive. So we call them the true positive. Okay. B are people who don't have the disease and they test positive. So we call them false positive. C are people who have the disease and they test negative, and we call them false negative. And lastly, D are people who don't have the disease and they test negative, and so we call them true negative. Now, the A and the C are people who have the disease. The B and the D are people who don't have the disease. The A and the B are people who test positive. The C and the D are people who test negative. Now, let's look into the sensitivity. We actually discussed this last time, but we will be giving this discussion a little more detailed discussion. Sensitivity of the test. Okay, sensitivity is the ability of the test to detect those who have the disease. And I would like you to be able to understand sensitivity. I would like you to look at the denominator. The denominator is A and C, and we told you that A and C are people who have the disease. Among people who have the disease, how many of them truly have the disease? So that is sensitivity. Among those who have the disease, how many of them truly have the disease? So that's the ability of the test to detect those who have the disease. And so we have the true positive. We discussed this a while ago. These are the people with the disease and whose tests are abnormal. They test positive. And the false negative are people who have the disease but they test normal or they test negative. So we call them false negative. Now, class, let me just emphasize to you that sensitivity, that false negative rate is the complementary of sensitivity. Meaning if the sensitivity is 90%, the false negative rate is 10%, because the false negative rate is the complementary of the sensitivity, so such that sensitivity plus false negative rate is equal to 100%. Okay, so just to repeat that. Okay, if the sensitivity is 90%, the false negative rate is 10%, so that when you add the two, they should equal to 100, so that the false negative rate is the complementary of the sensitivity. Now, let's go to the specificity. The specificity is the ability of the test, to test negative if the disease is truly present. So, or among those who don't have the disease, that's actually the B and the D, among those who don't have the disease, how many of them will test negative? That is specificity. Again, to understand specificity, you need to look at the denominator, where the denominator says B and D. And if you recall, B and D are people who don't have the disease. So among them, who will be truly negative? D kasi is true negative. Now, so the true negative are people who do not have the disease and whose findings are normal, they are negative. Now, the false positive rate, on the other hand, refers to the percentage of positive results that occur in those in whom the disease is absent. Meaning, people who don't have the disease, they test positive. That's why we call them false positive rate. Now, again, the false positive rate class is the complementary of specificity. Is the complementary of specificity. If the specificity is 90%, the false positive rate is 10%. The false positive rate is 10%. Now, measures of accuracy of the disease. You see, different diagnostic tests for the same disease often is a trade between sensitivity for specificity, between sensitivity and specificity, or vice versa. Meaning, in general, the more sensitive the test is for the disease, the higher its false positive rate. And if the false positive rate is high, the specificity will be low. Because as we said, the specificity or the false positive rate is the complementary of the specificity. If the false positive rate is high, specificity will be low. Or if the specificity is high, and then false positive rate is low. Because the two are complementary. They are complementary. But as we said a while ago, the different tests for the same disease often trade sensitivity for specificity. So if the sensitivity is high, the specificity goes down. It's just like, very much like a seesaw. When sensitivity goes up, specificity goes down. When specificity goes up, sensitivity goes down. So in much the same way, a test with higher specificity will sacrifice sensitivity by increasing its false negative rate. Because as we said a while ago, the false negative rate is the complementary of your sensitivity. The complementary of your sensitivity. Now, this makes a highly sensitive test ideal for screening, and highly specific tests are best in confirmatory role. Meaning, let's put it this way. If you want to rule out the disease, you need a highly sensitive test. If you want to rule out a test, you need a highly sensitive test. Because, as we said, highly sensitive test is ideal for screening examination, for screening. You want to screen people who have the disease. So you screen them. So what is left are people who don't have the disease. For example, if you want to transfuse blood to a patient with hemorrhage, okay, so you want to transfuse blood to the patient, you need to screen the blood for HIV test, for HIV/AIDS, I should say. There are actually 5, but we'll just zero in on HIV. So we need to screen the blood for HIV, so that if I give the blood to the patient, that means I have screened the blood, meaning the blood is free from HIV. So when we talk of screening, we actually are talking of people who don't have the disease. So that, as I said, to rule out the disease, you need a highly sensitive test. In much the same way, to rule in a disease, you need a highly specific test. That's why it's good for confirmatory role. Let me just give you an example. Let's go back to my transfusion, blood transfusion. We need a highly sensitive test to be able to detect people who have HIV/AIDS. We need a highly sensitive test. And ELISA is a very sensitive test for HIV, so that because it is highly sensitive, the false negative rate is very small. A test that's highly sensitive, let's say 99.9%, there is only 0.1% false negative rate. So that when you get a patient that's negative, you are sure that the patient does not have the disease, because the false negative rate is very low in a highly sensitive test. Do you follow? Now, but unfortunately, a highly sensitive test will have high false positive rate. They will have high false positive rate. That test will test positive for a number of people, and they are false negative. Now, if the false negative rate is high, because if the false positive rate is high, because false positive is the complementary of your specificity. If the false positive rate is high, specificity will be low. Specificity will be low. So you need a test that's more specific, that's highly specific, to be able to confirm. So you need another test that's highly specific to confirm whether the patient that tests positive for ELISA really has the disease. Okay. When we talk of highly sensitive test for screening and highly specific test for confirmatory role, we're actually talking of predictive indices. You might get confused. Why is it that we are talking of ruling out, and yet we are talking of sensitivity? Ruling out, and then we are talking of ruling in, and then we are talking of specificity. Since in our definition of sensitivity, we talk of people who have the disease, and in specificity, we talk of people who don't have the disease. So why do we say that for ruling out, we need a highly sensitive test, and for ruling in, we need a highly specific test? Actually, the reason for that, class, is we're actually talking of predictive indices. To rule in, when we talk of rule in and we talk of rule out, we are talking of predictive indices or predictive values. We have two: the predictive value of a positive test and the predictive value of a negative test. The predictive value of a positive test is more commonly known as the positive predictive value, and the predictive value of a negative test is more commonly known as the negative predictive value. But I would like this term, predictive value of a positive test and predictive value of a negative test, because they tell us what their meaning is. The predictive value of a positive test is that if the test is positive, what is its predictive value, or what is the probability that the person has the disease? The predictive value of a negative test means if the test is negative, what is each predictive value? What is the probability that the patient does not have the disease? So let's first talk of predictive value of a positive test. Again, the predictive value of a positive test is the probability that the patient has the disease given that the test is positive. So, if the test is positive, what is each probability that the patient actually have the disease? Again, when you look at the predictive value of a positive test, I want you to look at the denominator. A and B, as we said a while ago, are people who test positive. So, among those who test positive, how many of them are truly positive? So, that's the predictive value of a positive test. Now, the predictive value of a positive test is dependent on two things: the prevalence of the disease and the specificity. The prevalence of the disease and the specificity. The higher the prevalence of the disease, the higher will be the predictive value of a positive test will be. Now, if the specificity is high, okay, the predictive value of a positive test will also be high. But even if the specificity is high, but if the prevalence of the disease is not that high, and then the predictive value of a positive test won't be that high. Now, however, if the specificity is 100%, then the predictive value of a positive test is also 100% regardless of the prevalence of the disease. So, meaning, even if the prevalence of the disease is very low, if the specificity is 100%, then the predictive value of a positive test will also be 100%. Why? You know why? Because what, again, did I tell you is the complementary of the specificity? The complementary of the specificity is false positive rate. So that if the specificity is 100%, the false positive rate is equal to 0, meaning there is no false positive rate. There is no false positive rate. But because there is no false positive rate, when a person tests positive for the disease, then it must be true positive, because the false positive rate is 0 if the specificity is 100%. Okay. Now, let's go to the predictive value of a negative test. The predictive value of a negative test is really the probability that the patient does not have the disease given that the test is negative. So again, if you to be able to understand predictive value by a negative test, I want you to look at the denominator. The denominator says C and D, and C and D are people who test negative. Among those who test negative, how many of them are truly negative? Okay. So again, the predictive value of a negative test is dependent on also two things: the prevalence of the disease and sensitivity this time. Now, the lower the prevalence of the disease, if the prevalence of the disease is low, then the predictive value of a negative test will be high. Predictive value of a negative test will be high. And that seems to be logical, because if the prevalence of the disease is very low, and if you get a person and then test that person will be truly negative. So the predictive value of a negative test will be high. Now, if the sensitivity is high, the predictive value of a negative test will also be high. But even if the sensitivity is high, but the prevalence of the disease is high, and then the predictive value of a negative test won't that be high. However, if the sensitivity is 100%, then the predictive value of a negative test will also be 100% regardless of the prevalence of the disease. You know why? Even if the prevalence of the disease is high, the predictive value of a negative test will be 100% if the sensitivity is 100%. Because if the sensitivity is 100%, we told you that the complementary of sensitivity is false negative rate. So the false negative rate is 0, meaning there is no false negative rate when the sensitivity is 100%. So that when a person tests negative for the disease, then it must be truly negative. It must be truly negative because there is no false negative rate. And so I talked about ruling in and ruling out. We just want you to understand ruling in and ruling out. Why is it that in ruling out we need a highly sensitive test? And ruling out meaning the test is negative. If the test is negative, what is the probability that the patient does not have the disease? So we need a highly sensitive test so that if the test is highly sensitive, the false negative rate is very low. So that if the person tests negative, then it must be truly negative. So the predictive value of a negative test will be high. So I told you a while ago that when we talk of ruling in and ruling out, we're actually talking of predictive indices. And you need a highly sensitive test to be able to have a high predictive value of a negative test. In much the same way, when we talk of ruling in, I told you ruling out for sensitivity. For when we talk of ruling in, we are talking actually of the predictive value of a positive test. Kasi ruling in, the person tests positive. What is its probability that the patient has the disease if the test is positive? Now, with a highly specific test, the false positive rate is very low. So you need a highly specific test so that the false positive rate is very low, and when the person tests positive, it must be true positive. And that's the reason why a highly specific test is needed to rule in the disease. Actually, some people have a mnemonics for this, no? Spin means specificity, you rule in. So you need a highly specific test to rule in, and snout, you need a highly sensitive test to rule out. Snout sensitivity, out to rule out. Well, that's a good mnemonics, except that you need to understand why. Why do you need a highly specific test to rule in, and why do you need a highly specific test why do you need a highly specific test to rule in, and you need a highly specific test to rule out? Sensitive test to rule out, I should say. Now, having discussed to you the predictive indices, we'll now discuss the Bayes theorem. Well, Bayes is an 18th century statistician. His full name is Thomas Bayes, and he solved problems related to pre-test and post-test probability using a theory of conditional probability. This theory allows pre-test probability to be separated from a term that describes the strength of a diagnostic test we call the likelihood ratio. We'll discuss. This is the formula of the Bayes theorem, and I want you to understand this and even memorize sana, because these are actually asked in the board exams, and even in the licensure exams, and even in the diplomate exam. For example, this was asked in the diplomate exam for in family medicine, and and I would like to believe in other subjects, in other specialty as well. Now, so post-test odds, this the Bayes theorem formula are equal to pretest odds times the likelihood ratio. So we will now discuss to you, because we have mentioned the likelihood ratio, we need to discuss the meaning of likelihood ratio and even the odds. Okay. Now, both the predictive values of a positive test and the predictive value of a negative test are dependent on the prevalence of the disease. We told you that the predictive value of a positive test and predictive value of a negative test are dependent on the prevalence of the disease. So that in research, we normally do not measure the predictive value of a positive test or predictive value of a negative test, even if a lot of people do. But I normally say to people that don't add, when they talk, for example, of sensitivity and specificity or accuracy of the test in a research, they will normally add the predictive value of a positive test and the predictive value of a negative test. But I tell people, you don't include the predictive indices because they cannot be generalized to the target population. Because as we told you, when we make a research, we normally generalize our results from target to population. From sample to population. But with predictive indices, you cannot generalize this one because the predictive indices are dependent on the prevalence of the disease. Now, there is one other index that we use to calculate the likelihood of the disease that are not affected by the prevalence of the disease. We call this likelihood ratio, and these are proportions of probabilities. Okay. We also have what we call the positive likelihood ratio, and the positive likelihood ratio is the likelihood ratio of a positive test result. We also call it LR positive. Is the ratio of the true positive rate sensitivity divided by the false positive rate. And the false positive rate, as we said, is the complementary of the specificity 1 minus specificity, or 100. If you multiply this one by 100, so 100 minus specificity. Now, if you can recall the formula for the odds ratio, the odds ratio is A divided by B. That's the odds of the disease among the exposed, A divided by B. In much the same way, for you to be able to memorize the positive likelihood ratio, the positive likelihood ratio will just be, the formula will be the true positive divided by the false positive, or the complementary of the specificity 100 minus specificity. That's the likelihood ratio for a positive test, LR positive. Now, LR positive can be thought of how much more likely the patient is to have the disease after a positive test result. You will note, class, that the likelihood ratio positive has very much the same concept as the predictive value of a positive test. Because we told you that the predictive value of a positive test means if the test is positive, what is each probability that the patient has the disease. Now, with likelihood ratio, more or less the same. When the test is positive, what is its likelihood? When we talk of likelihood and probability, they seem to be very much related, but there is a technical difference between likelihood and probability, because as we said, the probability means this one, A, divided by the sum of A and B. That's the predictive value of a positive test. That's the probability of the disease. But in a likelihood ratio positive, the formula is A divided by B, or true positive divided by false positive. So that's the meaning of likelihood. The likelihood of the disease when the test is positive. The formula is true positive divided by false positive rate. Now, we talk of the negative likelihood ratio. The likelihood ratio for a negative test, LR negative, is calculated by dividing the false negative rate, this one, The false negative rate, that's also the complementary of the sensitivity. That's why it is also called 1 minus sensitivity or 100 minus sensitivity. So the false negative rate divided by the true negative. The true negative. So again, okay, this is a little bit difficult. I mean, you might get confused. This is a little bit confusing, I should say. Now, the negative likelihood ratio is a little bit, you'll be confused a little bit, no, because the negative likelihood ratio is unlike the predictive value of a positive test. Well, they seem to be the same, except that there is a big difference in the negative likelihood ratio and in the predictive value of a negative test. While I told you a while ago that the predictive value of a positive test and the likelihood ratio positive have more or less the same concept, with the negative likelihood ratio, there is a little difference. Listen. Okay. When we talk of the predictive value of a negative test, we told you that it means that if the person tests negative, what is each probability that the person does not have the disease? Notice, the person does not have the disease if the test is negative. That's the predictive value of a negative test. Now, look at the negative likelihood ratio. The negative likelihood ratio, well, sabi dito, it provides the strength of a negative test result that the patient is indeed free of the disease, but it's not accurate. The more accurate definition for the negative likelihood ratio is, if the test is negative, what is the likelihood that the patient has the disease? You will note that with predictive value of a negative test, if the test is negative, what is the probability that the patient does not have the disease? But with negative likelihood ratio, if the test is negative, what is the likelihood that the patient has the disease? Not does not have the disease. What is the likelihood that the patient has the disease if the test is negative? If the test is negative. Okay, I would like you, class, to have that thought, that concept, to be able to understand this likelihood ratio. Now, a likelihood ratio 1 is a useless test. A likelihood ratio 1 is a useless test. Likelihood ratio positive are always greater than 1. The larger the value, the larger the number, the more likely is the patient to have the disease after a positive test result. So if the likelihood ratio is high, so the likelihood that the patient has the disease is also high. Now, likelihood ratio negative are always less than 1. The smaller the value, signifying lower risk for the disease. You will note that it says here lower risk for the disease. So if the value is very small, 0.001, kasi it should be less than 1. Likelihood ratio should be less than 1. So if it's 0.001, the likelihood that the patient has the disease is very, very small. Because I told you that with negative likelihood ratio, we are talking of likelihood that the patient has the disease. So if the value likelihood ratio negative is always less than 1, if the value is very, very small, the likelihood that the patient has the disease is very, very small. And I would like you, class, to look at this table. Okay, so a likelihood ratio positive, that's 10 and above is an excellent test. Meaning, if the likelihood ratio of the test is 10 and above, that's excellent. Meaning, the likelihood that the patient has the disease is very high. Excellent. Now, a likelihood ratio equal to 0.1 negative, likelihood ratio negative equal to 0.1 is also an excellent test. Meaning, if the likelihood ratio is 0.1 or below, the likelihood that the patient has the disease is very small. 0.1, that's very small. Para bang 0.1 to 1. Ito naman, the likelihood ratio that the patient has the disease is 10 to 1, meaning 10 people with the disease, 1 people they don't have the disease. So 10 to 1. So the patient must have the disease because the value is 10 and above. Now, in much the same way, when we test the likelihood ratio negative, when the test is negative, what's the likelihood that the patient has the disease? Very small, 0.1, no disease, to 1 with the disease, So what's the likelihood that the patient has the disease? Very, very small, 0.1. So that's excellent. Now, a likelihood ratio positive 6 is very good. So a likelihood ratio 0.2 is also very good. A likelihood ratio equal to positive 2 is fair. 0.5 is fair. 1, likelihood ratio 1, likelihood ratio negative and positive equal to 1, that's a useless test. Okay, class. It would be good sana if we have an interaction, because my question to you is that when do you get a likelihood ratio equal to 1? Likelihood ratio positive, likelihood ratio negative equal to 1. When do you get that? Remember that we are talking of ratio. And when we talk of ratio, the formula for likelihood ratio positive is sensitivity divided by false positive rate, or true positive divided by false positive. So you will note that that's a ratio. Okay, unlike the predictive value is not a ratio, it's a proportion. Kasi a ratio, when we talk of ratio, the numerator and the denominator are different. When we talk of probability, the numerator is part of the denominator. But in a ratio, the numerator and the denominator are different. So that a likelihood ratio is true positive. Likelihood ratio positive is true positive divided by false positive. So when do we get a value that's equal to 1 for likelihood ratio equal to 1? When do we get? We get a likelihood ratio positive equal to 1 if the numerator and the denominator are the same, are equal. They are the same, because if the numerator is equal to the denominator, the likelihood ratio will be equal to 1. Now, in much the same way, when we talk of likelihood ratio negative, okay, and the formula, that's also a ratio, of likelihood ratio is false negative divided by true negative. That's a ratio. False negative divided by true negative. So, when do we get a value, a likelihood ratio negative that's equal to 1? Again, if the false negative is equal to the if the false negative is equal to the true negative, so the numerator is equal to the denominator, and they should be the likelihood ratio should be equal to 1. Now, when do we get so the answer for my question is, when do we get a 1 for likelihood ratio positive and likelihood ratio negative is also 1 when the numerator and the denominator are the same. Now my next question is, when do we get a likelihood ratio that's equal to 1 and at the same time the likelihood ratio negative is also equal to 1? When do we get that? So we can only get it if the sensitivity is 50% and the specificity is also 50%. If the sensitivity is 50%, the false negative rate is also 50%. The complementary of sensitivity is false negative, that's also 50%. Now, if the specificity is 50%, the false positive rate is also 50%. So all values A, B, C, D are 50. All A, B, C, D, A, B, C, D are all 50. So that the likelihood ratio uh, positive is equal to 50 sensitivity, and false positive 50, 50 divided by 50, the likelihood ratio is 1. And in much the same way, the false negative is also 50, and the specificity is also 50, the likelihood ratio negative is 1. So that's a useless test. It's very much the same as a toss of a coin. Does the person has the disease? You toss a coin. Okay, so if it is a head, then the person has the disease. If it is a tail, then the person does not have the disease. So that's a useless test. So a likelihood ratio equal to 1, likelihood ratio positive or negative equal to 1, the test is useless. The closer the value, the likelihood ratio to 1, the poorer the test is. The poorer the test is. Okay, so I hope you have understood the meaning of likelihood ratio. Now, let's go back to the Bayes theorem. We told you that the formula for the Bayes theorem is post-test odds and is equal to pre-test odds times the likelihood ratio. We have discussed likelihood ratio, and you know now the formula of the likelihood ratio. Now, let's discuss post-test odds and pre-test odds. This form of Bayes theorem using likelihood ratio requires conversion of pre-test probability, which we discussed a while ago at the beginning of my lecture. We convert the post-test probability to odds, and then so it is now the pre-test probability, which we told you is the initial subjective clinical impression of the physician. You convert it to odds, and then it now becomes pre-test odds. Okay, and then you multiply that by an appropriate, by what you appropriate, meaning what you calculated, the calculated likelihood ratio. So you multiply the pre-test odds by the likelihood ratio. That is now your post-test odds. Because we have the post-test odds, we now convert the post-test odds to post-test probability. So because the result is a post-test odds, we will convert now the post-test odds to post-test probability. So technically, we're actually talking of refinement of the pre-test probability after a test to a post-test probability. We talked about refinement from pre-test probability to post-test probability. Now, let's give an example. Using the Bayes theorem. What's the probability of Alzheimer's disease in a patient with positive MoCA? MoCA is Montreal Cognitive Assessment Test. What's the probability that the patient has Alzheimer's disease if the test for MoCA is positive and it has a sensitivity of 75%? MoCA has a sensitivity of has a specificity of 75%, a sensitivity of 75% and a specificity of 85% if the disease has a pre-test probability of 70%. So we told you, class, that when we talk of pre-test probability, we are giving a value, a percentage value to that patient, the probability that the patient has the disease. How do you get the pre-test probability? Well, as I told you, that depends on we told you the pre-test probability is based on your subjective initial impression from your history and from your physical examination, and then based also on epidemiology, based on the prevalence of the disease, based on whether the disease is common nowadays, because for example, there is epidemic for the disease, so based on epidemiology. So, and then we just give a value. And this value is a subjective value. So, suppose, for example, after you have a patient, you think with Alzheimer's disease, but you are not very sure, and you give him the probability of Alzheimer's to be 70%, and then you give a test, the MOCA, it has 75% sensitivity and 85% specificity. Now, we will now refine this pre-test probability to post-test probability after we test the MOCA, after we do MOCA test. And then, if the test is positive, what becomes of the post-test probability? Okay, so we will use the Bayes theorem to be able to answer that question. And Bayes theorem says post-test odds are equal to the pre-test odds times the likelihood ratio. Now, these are the steps. First, we convert the pre-test probability to odds. In the formula of conversion of pre-test to odds, the formula is odds are equal to probability divided by 1 minus probability. That's the formula for the odds. Probability divided by 1 minus probability. So we told you that the probability that the patient has, the pretest probability of the patient having Alzheimer's disease is 70%, that's 0.7, divided by 1 minus 0.7 is the probability divided by 1 minus 0.7, and that's equal to 2.33. So, or 0.7 divided by 0.3, 0.70 divided by 0.3, that's equal to 2.33. So the post-test odds, the pre-test odds are equal to 2.33. That's pre-test odds. Okay. Now, we told you that, we told you that post-test odds are equal to pre-test odds times the likelihood ratio. So we'll calculate for the likelihood ratio. We calculate for the likelihood ratio. We know that the sensitivity is likelihood ratio positive is sensitivity divided by 1 minus specificity, or this is the false positive rate. So the sensitivity, we told you, is 75% divided by 1. The specificity is 85, so that's 0.15. So 0.75 divided by 0.15, that's equal to 5. So the likelihood ratio is equal to 5. Now, calculate now the Bayes theorem, because we already have the pretest odds, that's 2.33, and we also calculated the likelihood ratio, that's equal to 5. So 2.33, the post-test odds are equal to 2.33 times 5. This is the likelihood ratio, that's equal to 11.66. So 11.66 is the post-test odds. 11.66. Now we convert the post-test odds to post-test probability. And the formula is the probability is equal to odds divided by 1 plus odds. So that's the formula of the probability conversion from odds to probability. The formula is probability is equal to odds divided by 1 plus odds. So the odds are equal to 11.66 divided by 1 plus 11.66, that's 12.66. So 11.66 divided by 12.66, that's equal to 0.92 or 92%. 92%. That's the post-test probability, 92%. Meaning, so you have a patient, we told you a while ago, we have a patient whose pretest probability is 70%, and then we did the MOCA, and then we found out the MOCA has 75% sensitivity and 85% specificity, And then, so we calculated the odds, the likelihood ratio, we calculated the post-test odds, and then we converted the post-test odds. So from the post-test probability is now equal to 92%. So the pre-test, as we said, is 70%. You refine the probability after a positive BOCA. The probability now that the patient has the disease after a positive BOCA is 92.1. That's the probability that the patient has Alzheimer's disease given that MOCA test is positive. Now, the method of Bayes' theorem that we talked about a while ago requires multiple steps. It is inconvenient for bedside use because a lot of steps, a lot of calculation. Now, in 1975, Fagan published a nomogram for graphical calculation of the Bayes' theorem. So, this Fagan in 1975 published a nomogram to calculate for the Bayes' theorem because, as we said, the Bayes' theorem seems to be complicated. A lot of steps. Well, it's not really that complicated. A lot of steps, a lot of calculation. So this Fagan published a nomogram. This is actually a nomogram. Okay. Now, anyway, if you can see this one, so a while ago, this is the likelihood ratio, this is the pre-test probability, and this is the post-test probability. So this one, these are the likelihood ratio. Just point, the likelihood ratio that we calculated is 5. Can you recall? Likelihood ratio that you calculated is 5. Just put a ruler. Actually, the nomogram has a slider. Now you can slide it up or you can slide it down. Okay. Now point to the likelihood ratio. That's equal to 5. This is 5 likelihood ratio. And then you go to the pre-test probability. That's 70%. This is 70. If you can read that, this is 70%, and then you put that to the ruler, the straight line, to connect it to the 5. That's the likelihood ratio. And then you connect it there, and then the post-test probability is equal to this 90, about 92.1. Okay, this is 92.1. So that's what Fagan did to be able to calculate for the post-test probability given a pre-test probability, and given calculating the likelihood ratio, you'd be able to get the post-test probability. Unfortunately, the nomogram is not that available anymore. When I was a resident in family medicine, and that was many years ago, when I rotated in internal medicine, they taught us the nomogram. I don't know why nomogram is no longer taught in internal medicine. It's only taught now in family medicine when we talk of EBM. Now, but nomogram is not available anymore. It's not popular anymore. As a matter of fact, very few people know what nomogram is. So what I did was to make a what do you call this? Another method. I call it actually the MIA method. That's actually the Excel program that I gave. You can go to that Excel program, and probably next meeting when we meet, we'll be showing to you what that MIA method is, so that it does calculate very quickly the post-test probability given the pre-test probability and the sensitivity and the specificity. It will calculate the likelihood ratio, and it will calculate the post-test probability. I actually call it the MIA method. MIA MIA is mechanized integrated approach because it's mechanized, it's integrated because a lot of integrations there. Anyway, but really MIA is a Spanish which means my, because that's really my method. Well, that's not my method actually. That's Bayes theorem method, except that I made a program. So well, now just a joke. That's not my method, but I call it the MIA method. Class, that's the end of my lecture. Hopefully you understood, and then we'll ask if you have any questions to my lecture, and then we'll show to you the MIA method in calculating for the post-test probability given the pre-test probability and the sensitivity and specificity of a test. Okay, thank you for listening.